Hi, this is Elliot Fishman, and welcome to our latest edition of Facebook Live. Today is Thursday, March 11th. Let me see if I moved correctly. No, I moved the wrong way. I'm moving this way. And you can see I'm in my dining room, our formal dining room, which we never use. This is where I do my recording. This is a blue microphone. You see that? Looks like a space thing, but it gives the best sound. We use that for all our CTisus lectures. And I hope everyone's doing well. So, welcome everybody here. You can see my hair is growing longer. This is the longest, I think. Look at that. It's really long hair. And today I'm home because I had a million phone calls and meetings, and also I'm getting a haircut. So you see that either I have to get this in braids or I have to get a haircut. So I'm getting a haircut today. That'll be kind of cool. I do hope everyone's doing well. We notice in the world things are getting a little bit better with COVID, but I think everyone needs to be careful. 13% of the population is now vaccinated. They're vaccinating 2 to 3 million people a day. The supply of the vaccine is not the issue. And you can see from the government now, it looks like by the beginning of May, everybody who wants to be vaccinated will be vaccinated. So that part is going well. You can see Alaska, for example, anyone above 16 can get vaccinated now. There's no wait. So I think things are going to get a whole lot better. I think, again, it's this one of the things you probably notice, like I notice, depending what, not that I watch the news, but what you read in the paper, it looks like some states have made the conclusion that COVID is over. Think Texas, think Connecticut. And other states like Maryland, it's getting a little bit better, but it's still a lot of caution. And at the hospital, we have extreme caution. The CDC announced the other day that if you're around people in smaller groups and they're all vaccinated, you don't need to wear your mask. So there's lots of different things, but it's going to be hard to tell. If you ask me the question, when are we going to have a meeting in person, I would say no earlier than first quarter of 2022. If you ask me when am I going to be in the hospital in the reading room without a mask on or walking through the hospital with no mask on, I can tell you I have no idea when that will be the case. That's going to be one of the challenges, I think. Hopefully, with the vaccine in full swing, with the season, remember last summer things weren't quite as bad. People are outside, the weather helps, and then things come back with a vengeance in the fall. So hopefully, a combination of vaccine and weather will make the summer a bit more pleasant, and hopefully we will be approaching herd immunity, whatever that means, by the fall, and so kids can all go back to school. I don't think vaccinations for kids under 16 are going to happen anytime in 2022, perhaps for 12 to 16-year-olds. Pfizer has finished their testing, but then the under 12 are a little bit more tricky. So it's possible the 12 to 16 can get vaccinated by the time school starts in September, but the under 12, I think, is going to be late 2021 or early 2022 before any real numbers are known. So it's not going to go away overnight. I think we just need to realize that. Now, I'm speaking about large adrenal masses today, and I'll tell you that I've done a lot of large adrenal masses today. Now, why I say that is I recorded 4 CTisus lectures, which I've put together over the past couple of weeks on large adrenal masses. Went through a differential diagnosis and some of the key findings we use to make very specific diagnosis. So I think you'll like the lectures. Remember, we always try to be a little bit ahead of the game. So I think these lectures will be coming out during May. Okay, so our production is finished. Sarah will do some work on them and clean them up and put them on YouTube, but I think we won't be announcing them. One little trivial hint I can tell you is we put up a lot of things early on YouTube. If you go into YouTube, you can find a lot of things if you look under CTisus, and we have a big YouTube channel, and we have something like 28,000 followers, subscribers on YouTube. So that's that's our main platform for video stuff. I think that becomes very important. Also, we have a big following on the Apple Store. And then, of course, we put things on the website, but it's really YouTube is where you're going to find all our videos. So let's see. I'm trying to think here if people make comments. I will. Let me see. Not set. Do I have to only your followers? Discussion, comments. Nah. So anyone who puts, I can't tell if I have the comment set right, but if you have a comment, you can put it down and we'll be happy to answer it. But in large adrenal masses, so I define large adrenal masses as masses over 4 centimeters. Remember, we typically talk about adenomas, which is a lesion up to 4 cm, well defined. On non-contrast, if it's under 10 Hounsfield units, is an adenoma. But not every adenoma is a lipid-rich adenoma. That's about 70 to 80% of the lesions. Then we talk about washout values, where you look at the non-contrast, you then look at a density value at 60 seconds, and then at 15 minutes. And if it washes out more than 60%, then it's an adenoma. Exceptions would be pheochromocytomas. So most of the small adrenal lesions are going to be benign adenomas, could be cysts. But of course we know that you could have metastasis, you could have even a primary adrenal carcinoma, which can be 3 centimeters if a patient has Cushing's and they're really hyperfunctioning and they present because of syndromes. But the 4 cm are more of a challenge because typically you can't call things adenomas if they're over 4 cm. We know there are benign lesions over 4 cm because we think about cysts, that's benign, can be large. We think about myelolipomas, can be large. We think about pheochromocytomas, which that's a good size, and pheo's only 10% are malignant. There was an article from Mayo Clinic, and I quote this article in my lecture, that made the point that about, if you take lesions over 4 centimeters, in their experience, 1/3 of them are going to be malignant. Now, obviously, older patients, more likely men, patients with clinical symptoms, that's going to be more likely a malignancy, and surely if you have a known primary, that makes it very easy. But it means that 2/3 of the lesions, more than 2/3, are going to be benign. So the question is, how do you recognize them? So I spoke about different lesions. So I spoke about cysts, water density, maybe a septation, maybe a little bit of rim calcification. Then we spoke about adenomas. Now, one of the challenges and the cases I showed adenomas that were up to 10.5 centimeters. They looked solid. They had some enhancement perhaps, some didn't, but they weren't low attenuation, they were soft tissue attenuation. Now the reason I know the answer to those cases is because they were resected. When you have a large mass, it's typically going to be resected, and I did not think those were adenomas. I didn't know what they were. They didn't look aggressive, but I could not call them benign. Now one thing to remember, and this is important, one of the things CT is very good at is determining aggressiveness of tumors. Now why is that important? If a tumor is going to be resected, you could resect it laparoscopically or with an open procedure. Laparoscopic, the patients are out of the hospital in a day or two. When you do it open, it's a big incision, and they're in the hospital 5 to 7 days. So you want to be doing things, if you can, laparoscopically. But the caveat is, if you think something is malignant, you want to do it open because even though it looks defined, you want to resect all the nodes. You can't resect everything when you do things with a laparoscopic procedure. So I think it's very important, and we go through some of the things that help you determine whether something is definitely benign or maybe better, definitely not malignant. So that becomes very important. We then spoke about what are masses above 4 cm that are worrisome. We spoke about primary adrenal carcinoma, 3 to 20 centimeters. Most are in the 7 to 10 cm range. They're irregular in borders, they're inhomogeneous, they can be vascular, they can have calcification. They kind of look ugly, but I showed some of them that were nice and round and solid masses, and I swear it looked identical to that giant adenoma. So it may not always be the easiest thing you can call. If you have vascular invasion, renal vein, adrenal vein, then it's more likely malignancy. Let me say hi to Lydiana. Hey Lydiana, who's calling in from Palo Alto area on the West Coast, which I'm sure is good weather and it surely has great scenery. So adrenal carcinoma, metastasis, we talk about that as well. Variable sizes. We talk about Mets, their vascularity. If they're very vascular, then we think about renal cell carcinoma. If they're very large, we talk about unilateral versus bilateral. We said very large bilateral masses, think of Mets, but think of metastatic melanoma, metastatic hepatoma. If you see adrenal lesions, unilateral or bilateral, large or small, truthfully, think about metastatic renal cell carcinoma. So we spoke about that. We also spoke about the vascular adrenal lesions that are larger. And again, you could think of Mets, but we always think about pheochromocytomas. Pheos follow the rule of 10. 10% are malignant, 10% are bilateral, but the bilateral ones are typically with syndromes like von Hippel-Lindau. We talk about the fact that pheos can simulate, particularly when they're smaller, adenomas because they have a high washout value. We have certain rules. If a thing enhances, if a lesion enhances more than 120, probably, but surely more than 130 Hounsfield units, it's always going to be a pheo. Pheos wash out quickly. There's no doubt about that, but it's that enhancement. Usually we see them 150 to 180. Pheos can have calcifications present, but not necessarily do they have calcifications. So that becomes a very important differential diagnosis. We then also spoke about malignancies like lymphoma. Lymphoma creates large adrenal masses that are soft and infiltrating, often bilateral. They often maintain the adrenal shape, but they're infiltrating and they're large. So you want to think about lymphoma. Now, I showed examples where it has that triangular shape and it's bulky and there's no adenopathy. You can have lymphoma where it's multi-organ, so you have adenopathy, you have maybe liver or splenic or pancreatic involvement. But one of the challenges with lymphoma is they don't always look like they're supposed to. Sometimes they're unilateral and it's just a large mass. Looks to me carcinoma, so it can be tricky. So I think in the classic case or in a select subsegment, you can be really, really accurate about what's going on. But other times, it can be problematic and you're not going to be certain. Bilateral is good for lymphoma. Lymphoma also involves often the peri and pararenal space. You can see contiguous involvement into the kidney. Now again, with lymphoma, we speak about most of the time it's multi-organ, systemic, adenopathy. Then it's fairly easy. I think the ones that are more challenging is when you have lymphoma primary in the adrenal gland where it's only in the adrenal gland. And I showed you a bunch of really nice cases, I think, that will probably help you in making that distinction. Now, we also spoke about hemorrhage, and I showed some really ugly cases that were actually benign lesions that had bled. Now, when you think about hemorrhage, the 3-centimeter range, we talk about trauma, then it's usually right adrenal gland. We talk about hemorrhage from anticoagulant therapy, Coumadin. It's usually rounded, oval, high-density fluid around the adrenal gland. Usually it's unilateral. If it's bilateral, you got to be thinking about the patient's Addisonian, which can be significant. But other cases with hemorrhage, you see large masses that have bled. I think it's a challenging diagnosis. I showed cases of adenomas that had bled. I showed cases of pheochromocytoma that had bled. I showed cases of metastasis that had bled. I showed cases of primary adrenal cortical carcinoma that bled. So what I'm saying is, many things bleed, but once they bleed, it's hard to recognize the lesion. Oh yes, I left out myelolipomas, which can bleed, which is why you resect them when they're over 5 centimeters because of the tendency for these lesions to bleed. So we spoke about the importance of hemorrhage and the difficulty hemorrhage provides you in even determining benign versus malignant. Often the lesions will rupture. You may see some periadrenal blood, but even when it's in the capsule, it's so large, 8 to 12 or 15 centimeters, and you see the high density, but you really don't see the tumor well. You can't make judgments as to what it is. So I think that's going to be a big challenge for everybody. I think in that regard, that becomes very, very important. So we are really looking at that very, very carefully, and I showed some nice examples. I also spoke about some unusual tumors. I showed a sarcoma, leiomyosarcoma of the adrenal, very rare, huge mass, looks like lymphoma, or maybe even a primary adrenal carcinoma. I spoke about some things like neurogenic tumors, or lymphangiomas, or hemangiomas. They're really rare lesions, and they just don't look like anything special. They don't look like simple cysts. They don't look like hemangiomas, and surely don't wash off like that. You think about some of the neurogenic tumors should be low density, but not necessary. So I think some of the unusual tumors tend to be diagnosed after surgery because it's just a really, really hard call to make, and you're just not that comfortable. But when you look at the rest of the things, I think by looking at the age of the patient, history of the patient, and the CT findings, you can be very specific as to what the diagnosis is. Is it adrenal carcinoma or is it lymphoma? Is it metastasis or is it pheochromocytoma? Is it malignant or is it benign? And is it benign, leave alone, or benign, you need to take it off, or something like that. So that all becomes very important, and that's kind of a very good strategy for looking at the adrenal gland. So does anyone have any questions in that? This is a quiet crowd today for March 11, but no, it's really challenging, what you can do with that. So I think that becomes important to us. So I think you should listen to the lectures when they come out. Again, one of the important things in terms of your practice and quality assurance is to get follow-up. A lot of the cases I described them, I didn't know what they were, and later on you got follow-up. So I have a little better feel now of how to deal with some of these lesions, but I'm still going to say to you that sometimes it's just really hard for me to be very specific what the lesion is. And again, listen to the talks, look at the cases. I've posted some of them. We've been posting things. If you go to our adrenal files on CTisus, the teaching files, there's lots and lots of cases of adrenal lesions, a range of sizes, a range of enhancements, a range of appearances. So I think that should be very valuable to you. So what else? That's about all I brought with me today, and that took me to the 16-minute mark. Lydiana has no question, but it's surprising no one has any questions. Well, it's interesting. We are noticing, I think, with everyone being busier and busier and losing track of time, it's harder to get people to Facebook Live, but we have lots and lots of people who check with us after Facebook Live is no longer live. Remember, you can go to Facebook, and this will be there forever, and I do post it at the top of the page for a couple days, or you can go on your YouTube channel and find it. Just choose us, and you will get notices when our things are posted, so that could be helpful to you. I know everybody is busy these days, so we do appreciate you being here. And there's some of the stuff from I guess it's probably Lily posting about where to go for some of the adrenal information. And Lydiana says it's raining. I thought it never rained in Southern California, but she lives in Northern California, which is where Stanford is. But I know it's if they get rain, it's probably they can use rain, because usually the West Coast is in a drought. It's rare that they have too much rain, and when it's too much rain, it's usually because it just rains too fast in a short period of time. So Lydiana, hopefully it stops raining, and hopefully you enjoy the rain. And with that, I guess let me say goodbye. Next week I'm going to look really distinguished looking when I'll have my hair cut. That's not possible, I guess. And Lydiana says they need the rain in California, so you got to fill up those reservoirs, and you got to water the grass and the lawns. And California has had just issues with droughts and then flooding. It's just hard to get anything right. So just hopefully this will be a good rain. So with that, I thank everybody for their attention, and see you next time.